for Patient Access, which is the European division of the Global Alliance for Patient Access. And my name is Neil Bettridge. I'm the Senior Director for EAPA. And as the title, I think, in a fairly self-explanatory way shows, we're going to be looking at high blood pressure or hypertension. So very briefly today, in order to move quickly to our discussion, we hope that this webinar will provide a resource mainly for patients and the general public, or anyone affected by or interested in the topic of hypertension or high blood pressure and how this can be best managed. And also, more excitingly, I think with changing times, look at the latest effective and innovative treatments which are becoming available and becoming more recommended through guidelines and so on. So, with no further ado, it gives me great pleasure indeed to welcome Professor Atul Pathak, who's a distinguished cardiologist and Professor of Cardiovascular Medicine at the Princess Grace Hospital in Monaco, Director of the ESH Hypertension Excellence Centre, and former President of the French Society for Hypertension. So I'm sure you all agree we couldn't have a better guest to talk us through these issues. What we're going to be covering is what hypertension is, what its impact is, and also what the real benefits are of ensuring optimal and timely treatment for patients. So with that in mind, Professor, what exactly is hypertension and what causes it?
Thank you, Neil, for having me on board. And again, really happy to share a couple of thoughts about this very frequent silent disease, which is hypertension. So hypertension is basically a disease which is known also as high blood pressure. We could also call this disease hyperpressure. It's been even easier for our patient to understand hyperpressure and hypertension. And you have to keep in mind that it's most of the time the most prevalent diseases around the world, but also in Europe. It is expected that more than 150 million patients are having hypertension. And so to keep it very simple, it's usually defined by consistent elevation of blood pressure. So, you know, when you go and see a doctor, you measure your blood pressure. And I always like to give the example of the car. It's not so much the speed of the car at a very instant moment, but it's the average speed of the car. So it's when your average blood pressure is above a threshold. The threshold is defined by two numbers. The top numbers is what we call the systolic blood pressure. If your blood pressure is above 140, 140 is a pressure. It's expressed in millimeters of mercury. Or if your second number of 90 millimeters of pressure, which is what we call the diastolic blood pressure. So if your numbers at your doctor's place or at home, if you have a device, we'll talk about this later, is above 140 over 90, it means that you have elevated blood pressure. And if it's repeatedly above 140 over 90, it's probably a sign that you have hypertension.
Okay. Is it fair and accurate to say that some patients may have numbers that look okay, but may still have some effect from high blood pressure?
Yeah, that's a very important question because it gives us indication about the fact that blood pressure fluctuates a lot. So you might have normal blood pressure and still have hypertension. And on the other side, you might have elevated blood pressure and not have hypertension. So in order to be sure that you are not missing the disease, there are two very important messages. One, measuring blood pressure outside the office of the doctor is more important than the blood pressure at the office place. Why? Because 30% of our patients have what we call white coat hypertension or elevated blood pressure when they are in the doctor's office, but it doesn't necessarily mean that they have hypertension. So the first message is you need always to measure blood pressure outside the office. Second, because blood pressure fluctuates, it's normal. I'm talking, my blood pressure is rising. You are maybe stressed, Neil, and your blood pressure is high. I'm exercising, my blood pressure goes up. It doesn't mean I've got hypertension. That's the normal regulation of blood pressure. But to overcome this fluctuation, you need to measure blood pressure regularly. So outside the office and regularly, chronically elevated are signs which are orienting us towards the diagnostic of hypertension or hyperpressure.
Thank you. That's really clear and very helpful. My blood pressure is already reduced. Pretty clear explanation of complicated issues. Thank you. So you've just informed us really how hypertension is measured, but how is it usually first detected?
Yeah, that's also a very smart question because it's difficult to detect hypertension. We call it sometimes, sorry for these words, the silent killer, because patient can live with hypertension throughout their life and never know they've got hypertension. So there are, let's say, two types of patients: those who are really having symptoms, headache, blurred vision, they have the feeling they are hearing an abnormal noise in their ears, they are expressing shortness of breath, or they even might have complication related to hypertension. So these are the very, what we call symptomatic patients, very having a lot of symptoms. They are usually tensed. They go to the emergency department, they go to see the doctor, and he will do the appropriate thing, which is measuring blood pressure. Then, but that's more frequent, you have what we call the silent patients, and these usually do not present with noticeable symptoms. They are undetected, they are uncontrolled, but it doesn't mean they are not at risk. And these patients might live with hypertension, have their blood pressure not controlled, untreated, and they will start to be diagnosed once they suffer from a complication. So that's why, and it's really a plea to all our audience, you need to be screened for hypertension. You need to be detected for hypertension and take every opportunity, whether you go to the pharmacist, you see your GP, you have a device at home, or you can even use the device of a friend to at least measure your blood pressure in order to detect what is usually a silent disease.
I see. So for those people who may be unsure whether to go to visit an emergency department or a GP about this, the message would be to do that, right? To go and get checked out.
Absolutely.
Because the doctor then will be able to advise whether you are just having an episode or whether you may be somebody who is vulnerable to this condition longer term, right?
You know, that's really a good point. We have been doing campaign to increase awareness about hypertension, and just measuring blood pressure in a supermarket or after a picture in a picture hall or at a theater is allowing you to detect usually 20 to 30% of people who were just sitting there and they were not aware that they had hypertension. So again, even, I mean, buying a device, okay, or if somebody is ready to offer you this as a gift for 10, 15 euro, 20 euro, you have a validated device. You can start measuring blood pressure at home. You can even measure blood pressure in your family. And by doing that, you are really doing something important for detecting this silent disease.
Okay, and I guess it depends what kind of movie you've just seen as well, on the scale,
Yeah.
on the scale of Walt Disney to The Exorcist, right?
But any opportunity to measure your blood pressure is well taken.
Sure, absolutely. Important point. Thank you. So along with the regular monitoring, how else can hypertension be effectively managed? And does that management mostly go on in primary care or secondary?
Yeah, I think to answer your question, and I skipped one of your question, which was basically what causes hypertension. And I think this is really important for our patient, because you have to understand, you have a silent disease. You are not aware of a disease, and suddenly somebody is telling you you've got hypertension and you need to treat, or you need to do a follow-up. It's a huge burden for a patient who was sitting exactly in the same condition, not suffering from anything. He never asked anything to anybody. And suddenly you are telling him, okay, you've got a disease, you've got a silent disease. So it might sometimes be perceived as something which is unfair, because you have not asked anything and suddenly you are classified as a patient while you were just a citizen entering a doctor's office a couple of minutes before. So there are many reasons why people have got hypertension, but surprisingly, we don't know. In 80 to 90% of the cases, we do not know why patients have hypertension. So there are a bulk of situations which are promoting hypertension. I go through that later on, but it's not like another disease where you have a heart attack because you had too much cholesterol, or you had a stroke because you smoked, and you may establish a causality relation. So why do I have something, and what is the consequence, cause-consequence? I was smoking, I had lung cancer. In the case of hypertension, things are not so easy. So in fact, there are two types of patients.
Mm.
A tiny part, 5 to 10%, who have what we call secondary hypertension. So in this rare case, you might find a disease which is inducing hypertension, and you might treat the disease and hypertension could disappear. These diseases usually affect the kidney or some glands which are on the top of the kidney, some vascular disease, some genetic disorders. So you identify them, you treat them, you cure the patient, but it's rare. I was saying 5 to 10 is more 1 to 5%. For the rest of the patient, it's more a variety of factors which are prone to increase the risk of having hypertension. So genetic, for example, and family history. If in your family, your father, your mother, or your brother and sister had elevated blood pressure, well, this raises the risk for you to have hypertension. Your age, I mean, the older you get, the less your blood vessels are moving nicely like elastic tubes. They're getting stiff, they're getting calcified. This increases the risk of hypertension, but also stress. The way you live, if you eat too much salt, if you are not moving enough, if you have elevated weight, well, all these, if you drink too much, all these factors are usually associated with an increased risk or associated with the risk of elevating your blood pressure. Okay, but it's not a single, common, easy to detect, curable cause. It's more a bulk of factors.
Right, because a lot of patients, I think, will ask, is it a genetic thing? Is it a lifestyle thing? And of course, this shows that it's all the more important to promote individualized care, right? Because there are so many factors specific to that individual. That's interesting to know. And apart from the monitoring and the factors which cause it, how else is hypertension traditionally or commonly managed? Are there probably effective treatments?
That's really important. So let's say you have established the diagnostic part and you want to manage hypertension. First, two very important information. Why do you treat a patient with hypertension? It's not just about regulating his blood pressure, which seems obvious, but it's also to reduce the risk associated with hypertension, because hypertension increases the risk of stroke, of heart attack, of kidney failure, but also of disorders from the vessels. So reducing blood pressure will reduce this complication, but the type of treatment you will offer to your patient is there to answer to these two challenges: reduce blood pressure and reduce the risk associated to hypertension. So how do you achieve that? Well, first, by what we call lifestyle modification. So all these factors we have been talking about: reduce your stress, reduce your sodium intake, try to control your weight, reduce your alcohol intake, try to eat less saturated food. I would say general rules we all know, which are healthy habits, which could be applied not only for hypertension, but for any cardiometabolic condition. Any patient at risk for cardiac disorder or for metabolic disorder, which are diabetes or obesity, would have to stick to this lifestyle modification. Second level of intervention, well, these are drugs. So there are several classes of what we call anti-hypertensive medicine, so drugs which are there to control our blood pressure. I'm not going to go into the name of these drugs, but let's say that there are a variety of classes of drugs which can be used. Now, the choice of medication depends on guidelines, but also, as you mentioned, about patient-specific profile, and you will adapt the treatment to what guidelines will ask you to do. So these are based mainly on scientific evidence, but then you have to adapt scientific evidence to the patient profile, and you will not treat in the same way an elderly and a young patient, a patient with diabetes and a patient without diabetes, a patient who experienced a stroke and a patient who has never any type of complication.
Sure. And you mentioned guidelines there, Professor. I noticed I think it was the recent update of ESH guidelines, that there was something called renal denervation mentioned as recommended for certain patients. Could you explain to us what that is, please?
Yes. So renal denervation is an intervention. Okay, and that's really a change in the paradigm, because we have been treating these hypertensive patients for years with lifestyle modification and drugs. And there are some challenges when you are offering, for example, drugs to the patients, because patients don't like to take drugs. Remember, they have a silent chronic disease, and you're asking them to do something every day where they are not suffering from anything. So renal denervation is an intervention where basically you will use what we call a vascular access, the same way you will do an angiogram. So you will bring through the vessel, through the femoral vessel, a very tiny wire into the renal artery. Now, the wire is something special because on the top of the wire, you will have a device which is able to, let's say, heat. And by heating, able to destroy some fibers. We call them sympathetic fibers, which are within the wall of the artery and which are involved in the induction of hypertension. So by destroying these fibers, you are able to reduce what we call the sympathetic burden. The sympathetic system is a nervous system which is overactivated in hypertensive patients. And by putting down the system, by decreasing the activity of the system, we have been able to show that you are able to reduce blood pressure. So you remove the wire. It's an intervention. We're not putting anything inside your body. It's just a procedure. You insert the wire, you treat the arteries, and you remove the wire. It's called renal because we are playing into the renal artery, and denervation because you are removing or at least putting at rest some nerves which are involved in the occurrence of hypertension. So renal denervation is a new procedure which has been validated by the European guidelines, as you asked, Neil, in which type of patient? Well, in patients who have a blood pressure which is not controlled, so above the threshold we have defined as 140/90, who have no secondary causes of hypertension, who have been managed by expert teams, and who on the top of drugs will be offered this procedure to optimize blood pressure control, but also, and that's very interesting, in those who are having side effects with drugs and who are not willing to take drugs, or in those who prefer to start to be treated with an intervention rather than to be treated with drugs. So a wide range of patients, let's say, who could be put under the umbrella of uncontrolled hypertensive patients. So patients who have their blood pressure not below the threshold and who needs to be optimized could be offered lifestyle modification, pharmacological treatment, and renal denervation. And I have to say, and or, because you could even start treating this patient with renal denervation. Are you on mute, Nia, I think?
Yes, I just realized my blood pressure rocketed when I just got thrown off this webinar. So thank you for continuing your very clear explanation. Sorry about that. Fantastic. Thank you, Professor. I think we're starting to get some questions coming in, actually, which I'd like to have a look at. So I see one here asking, do you encourage establishing a standalone clinic for hypertension management rather than treating it in cardiology, endocrinology, or internal medicine ward? Interesting question. Thank you very much, Matas, for asking that. Professor?
Yes, I think that's the change, not only in the field of hypertension, but let's say a general change in the way we practice medicine. Well, the modern way is absolutely to maybe minimize the patients staying in the ward or in the hospital, because most of the testing we want to do can be done ambulatory. So you could even chat with the patient like we are doing in order to ask him about his signs and symptoms, asking to measure blood pressure at home, and then see him as an ambulatory patient to perform additional intervention or examination. So you are absolutely right. More and more situations, you can do it outside the ward. But sometimes, I would say as a second step, if you are trying to find these secondary causes, so these curable causes, you might need to be hospitalized for 24 or 48 hours because you need to go through testing which are a bit more complicated. Sometimes complicated imaging techniques, sometimes measurement of biomarker while you are sitting or lying down, and then while you are standing up, so dynamic measurement of biomarkers. These type of investigation may require a short hospitalization, usually less than 24 hours. But in most of the cases, you can absolutely do it outside the ward.
Excellent. Good to know. And also, you mentioned earlier, Professor, around this aspect of self-monitoring as well, because it's a continuum and we need to identify different snapshots along the way, not only a one-off. You mentioned a validated measurement device, or what would that be, and how would a patient know which ones are validated? Should they ask their pharmacist or GP or go online? What would you advise?
So one very practical advice, we have a site called StrideBP, STRIDEBP.org, which is basically a site where you will have all the list of devices which have been validated by the European Society of Hypertension. Then nationally, for example, in the UK, you have the British Hypertension Society, who has on their own website the list of devices which are validated in the UK. Same for France. So there are websites, so the official ESH website or national websites, which are collecting the information about these validated devices. Second, you have two types of devices, the wrist one and the one measuring blood pressure at the level of your hand. You can use one or the other. The wrist device is more sensitive to the position, so you'll be asked to measure your blood pressure with the position of your hand at the level of your heart, not moving, not be contracted, while the device at the level of the arm is maybe more easy to use while you are laying down or even while you are sitting. Okay, so I prefer the arm than the wrist, but the wrist is tiny, easy to transport, and people like it. But I would say if you have the choice, I'd rather go with the arm device. A validated device, just refer to the list. And last but not least, all other wireless devices, fancy devices, are yet not validated as devices usable for the measurement of blood pressure. So really stick to the device which is measuring your blood pressure at the level of the wrist or at the level of the hand. Validated devices, but do not fall into the trap of buying these watches and ring and whatever, because these devices have yet not been validated for the diagnostic part of hypertension.
That's super advice. Thank you so much. It's great to have more and more patient choice, but it's even greater that patients make the right choice and go for validated, evidence-based procedures.
And Neil, if I may add, you can also on these sites find these type of charts. I'm just showing this to the audience, where basically what we are, sorry, it's maybe not very clear, where basically you are asking a patient to measure blood pressure 3 times in the morning while they are at rest, 3 times in the evening while they're at rest, 3 days in a row. It's easy to keep in mind. It's the 3x3 methods. 3 times in the morning, 3 times in the evening, 3 days in a row. You will get 18 values. And the mean value, remember the story of the car, the mean value or the mean value of these 18 values will be a very strong indicator. If it's above, I told you 140/90, when you measure blood pressure at home, the threshold is slightly lower. It's 135/85, but let's say keep in mind 140/90. If it's above, you have uncontrolled hypertension if you are already treated, or you are considered as a newly diagnosed hypertensive patient. If it's below, it means if you are an established hypertensive patient, your blood pressure is controlled. If you never experience hypertension, it means you do not have hypertension. So repeated measurement with a validated device at home will make the job.
Very clear. Thank you so much. I think we have time for maybe one more question. I see one has come in from Marios Koulimas, another of our on the Alliance, one of our distinguished patient advocates we work with. And the question is a great one, I think. If you started medicine and in the same time started doing, the lifestyle things, exercise, weight control, etc., would you possibly then be able to stop the medication as a result of a better lifestyle if that worked?
That's a really important question. I have to confess, we physicians tend to prescribe drugs because it's an easy way to control blood pressure and it's a fast way. But for our patients who do not like to take drugs, and we have to admit that, it's very important to share with them the information that reducing their weight, exercising, reducing the consumption of alcohol are very powerful tools able to decrease blood pressure. And I have patients where I've started at the same time drugs and lifestyle modification. And they have been so compliant to lifestyle modification. They were so motivated that their blood pressure went down and I could stop the drugs. And this is, I think, a very important message of hope for all these patients who do not want to take pills. Well, it's possible to control blood pressure if you change your lifestyle. Now, it's possible also that it's not enough, and that despite having done everything, we still need drugs, but then you have to accept that you will probably need less drugs at a lower dosage, which is also something acceptable. And finally, it's always about patient preferences and shared medical decision. There is the opportunity also to talk about renal denervation as an alternative to drugs for those who are not willing to take a pill for the rest of their life.
Understood. Thank you. Professor, we're almost at the end. I can't thank you enough for your time, but also for your incredibly clear explanations, which I'm sure patients and members of the public watching, I'm sure that they would all want much more of this, but we do have to stop in a moment. But it's been very clear, very helpful, very precise. I think some very clear messages, if I may attempt a very short summary, really, which is despite the prevalence and sometimes the severity of high blood pressure and the way it can have such a debilitating effect on many people, there is also good news here, that there are effective ways to manage. And patients have to take some responsibility for that, for getting checked out, for playing their part in monitoring and so on. But there are also developments which are helping, such as renal denervation in certain cases. So I think we have some good news in an otherwise very difficult area. So thank you for helping us to understand all of that, Professor. That's been tremendous. Thank you. This conversation will be available as a podcast to watch on the GAFPA website, gafpa.org. Please communicate it. Those of you watching, please share and communicate it with anybody you think might be interested. We also have a fast facts on this topic on the GAFPA website. So with all that in mind, thank you again, Professor. Thank you everyone who's been viewing, and I wish you all an excellent rest of the day. Thank you and goodbye.
Thank you.